Hello everybody, I'm Peter Hudson. Welcome. I'm the Director of the Centre for Palliative Care and the facilitator for this hot topic seminar on motor neurone disease. In the spirit of reconciliation, the Centre for Palliative Care acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. You're in for a bit of a treat this afternoon, everybody, because we've got three fantastic presenters, Mark Howard, Rowan Hearn and Susan Mathers, and we're going to, each of our presenters is going to have about 15 minutes or so, and then there'll be a chance at the end for Q&A. So we strongly encourage you to submit questions and comments via that option on screen, and you can either submit those as our presenters are delivering their talks, so that we've actually got a pool of questions at the end to draw from. So please don't hold back. You've got a team of experts here today on a very topical area of consideration, so it's a great opportunity to get feedback on particular matters they're going to be raising during their presentation. So that'd be great if you can use that particular option. I'd like to introduce our first speaker, and I should have said, sorry, that we've got full biographies of each of the presenters on our website, so I would encourage you to go to those bios so you've got a better understanding of the backgrounds of each of our presenters. But due to time, I'm just going to be providing a very brief introduction.
We'll start with our first speaker, and as Peter said, the full bios are available, so thank you very much, Mark, if you're happy to present.
Yeah, thank you very much. And thank you to Peter and the Centre for Palliative Care for inviting us to talk this afternoon. So looking forward to the discussion. I'm going to sort of set the scene, talking a bit about the background of why we use ventilation and other respiratory supports in motor neurone disease, what the treatments involve, and how we would go about supporting people, particularly in relation to the services in Victoria. So I'm aware that we've probably got a conference full of neurologists and also palliative care physicians, but I call this my respiratory physician's neurology slide. And so when we think about neuromuscular conditions where ventilatory support may be useful, there's a range of conditions that may affect different parts of the respiratory neurology, from brain stem to cervical spine, and motor neurone disease, of course, mainly the lower motor neurons that innervate the diaphragm and the intercostal muscles. Motor neurone disease is interesting and different to many of those other conditions because it affects all the different components, including the upper airway, which is important for breathing. So when we first breathe, the first muscles that are actually triggered off are the muscles in the upper airway, which contract to keep the airway and the throat open on inspiration. And so when those muscles become weak, you can actually get collapse of the upper airway as well as part of inspiration. And then you move into the intercostal and the diaphragmatic muscles contracting after that. Of course, when they contract, you create negative pressure within the chest to draw air in, with the diaphragm contributing about 70% of that inspiratory capacity. The other muscles important for breathing in neuromuscular conditions are abdominal muscles for expiration and coughing to clear secretions. So with progression of neuromuscular disease and motor neurone disease, it's weakness of all of these muscles that become important. And this results in reduction in breath size, and as that progresses, people's respiratory rate increases to try and compensate to have adequate flow of air in and out of the lungs to exchange oxygen and carbon dioxide. So what results as these muscles become weaker is people develop breathlessness on physical exertion, but importantly orthopnea, so difficulty in breathing when they lie flat. And before people go on to ventilation, many or most people will have developed some degree of orthopnea. So it's a key symptom and in its own right an indication for considering whether somebody wants to go on to therapy with ventilation. this difficulty with breathing is worse at night time because of the difficulty with lying flat, and that can then disruption to sleep, respiratory failure with development of hypercapnia during sleep, and the poor sleep quality can result in other symptoms such as impaired cognition and daytime sleepiness, and hypercapnia can cause headaches, particularly on waking in the morning. In the original studies by Burke, these are the sort of symptoms and the percentage of symptoms that people had when they went on to ventilation. And in most people, they'd reach lung capacity or vital capacity of less than 50%, so in about a quarter of patients. But some people will develop symptoms with vital capacity above that level. So it's a bit variable, but we use that sort of 50 to 60% mark as a guideline, thinking that people may benefit from going on to ventilation. Hypercapnia with raised carbon dioxide level tends to come a bit later, and most people won't actually have developed hypercapnia at the time that they go on to nocturnal ventilation. So what does non-invasive ventilation look like? Well, this is a slightly older machine, but non-invasive ventilation involves a small ventilator that applies extra pressure to the airway during inspiration that then drops down during expiration, and that augments or provides a bigger breath size or tidal volume. And the ventilator is applied through a tube, through a mask attached by straps around the face, and those masks need to be individualised, and the settings on the ventilator, including the rate of the ventilator, the amount of pressure support, needs to be individualised, and that may also change as the condition progresses. So if we set somebody up early on ventilation and they get weaker over 3 months or 6 months, the support requirements that they need later may be quite different. Oxygen level, below that is carbon dioxide, and the next is a pressure trace on the mask. So you can see up on the red line oxygen varying from 98 down to about 85%, carbon dioxide for this person sitting at 53%. And then if you look at that mask pressure trace, you can see where all of a sudden the pressure goes up and then back down and up again, and each one of those is a breath being delivered by the ventilator. Below that's the flow of air, and you can see the first couple of breaths there that the flow of air is higher, and below that we've got movement in green of the thorax and the abdomen. So good synchronisation between the ventilator delivered breaths and movement of the chest and abdomen. But then you can see a long period of about 40 or even 50 seconds where the movement just stops. The thorax and the abdomen movement is gone and the flow has dropped down. And that's most commonly due to collapse in the upper airway. I'm just giving you an example of where the ventilator is synchronising well with some breaths, but at other times it's not working well. And this underpins why we need to individualise and set up the ventilators appropriately for each person to make sure we can overcome these types of problems. These are two studies, on the top a diagnostic study and the bottom then a study on ventilation in the same person, in somebody with motor neurone disease. So it's a full night sleep study. And if you go to the top one, the very top line where it says REM gives us an indication of what sleep somebody's had during a night when they're off treatment with significant breathing muscle weakness. And the little bits green and then yellow across that top line are fragments of sleep during that night. So very short periods of sleep, and yellow and green are stage 1 and 2, so earlier sleep stages. And there's no deep sleep in that person. And towards the end on the top, you can see a tiny bit of red. That's a short period of REM or dream sleep. So very poor and fragmented sleep for the person. We come down then to SaO2, so that's just oxygen saturation. You can see that every time they go into sleep, the saturation drops down from the 90s at the start of the night down into the 80s, and during the REM period later in the night down into the 70s. And then below that is carbon dioxide at the start of the night up at 70, so quite high, but increasing up to 80 as soon as they go into sleep. So this person's got significant respiratory failure, which gets worse in sleep with very poor and fragmented sleep. And then in the bottom panel on ventilation, if you now look at those sleep periods, you can see longer periods of green and then blue, and blue is slow wave sleep, So nice blocks of sleep occurring throughout the night and much longer periods of about an hour of REM or dream sleep indicated by the REM period. So much better sleep quality, which can then improve tiredness and cognition during the day. So they then can result in improved quality of life. The oxygen saturation, you can see there, remains up close to 100% throughout the night on ventilation, and the carbon dioxide controlled down at 40 to 50% on ventilation during the night. So these are the benefits of being on the ventilator overnight, on a single night. If we then translate that to research, this is work from our group, from David Berlowitz, that on ventilation, the arousals from sleep were reduced, efficiency of sleep and total amount of sleep that patients had were improved by about 3/4 of an hour to an hour, and you improve the oxygenation overnight. So why does this then translate to improvements in quality of life and indeed into survival? The improved sleep quality and improved breathlessness while on your ventilator improves measurably respiratory related quality of life. So on the left side, the early studies by Burke, which were pre and post studies, he measured generic quality of life with SF36. Sacrally is a measure of respiratory related quality of life, and then ALS-FRS rating scale. And each of these improved over the next 6 months after individuals went on to ventilation. Burke then went on to do the first and really key randomised controlled trial of non-invasive ventilation in motor neurone disease. And the data I've shown here, which is on the right side in the red and blue, is the indications of decline or maintenance of quality of life at a baseline level in the blue in the non-invasive ventilation group, and then in the red in the control group. And so while both groups did have a decline over time, the decline in quality of life was slower in the non-invasive ventilation group compared to the control group. On the bottom of those panels, he's split the analysis into those with and without bulbar disease. And in his earlier study, what they found is that the quality of life improvements were predominantly in those with non-bulbar disease, whereas those with bulbar disease did not get those improvements. And I think it also relates into those studies to the methods for how people were ventilated, where they used mouthpiece ventilation during the day rather than mask for most patients, and that's harder for people with bulbar disease to use. He also found improvements in survival with similar trends, that the survival improvements were predominantly in those with non-bulbar disease. But we've subsequently looked at our analysis in the cohort, this in Victoria, and showed that the survival improvements actually held up across the board, including in people with bulbar disease. So this is looking at the different phenotypes, and again published with David Berlowitz, a team from Calgary and myself. And we use different methods in ventilation where people can use mask ventilation during the day and make other adjustments for people with bulbar disease. And so many of them can actually tolerate and use successfully and with good benefit non-invasive ventilation despite impaired bulbar function. So we then showed improvement in survival across the board in the different phenotypes, including those with bulbar impairment. So what I just want to briefly talk about the goals and decision making and why somebody would choose to start ventilation. And in Victoria, it's about 40–50% of patients who use to trial ventilation. So it's not everybody. And in some other areas, the rates of use are lower. So goals might include improvement of symptoms for breathlessness, impaired sleep quality, and impairment in cognition. Sometimes these symptoms might be due to other reasons. So they might be due to bulbar impairment or secretions in the upper airway, for example. So carefully teasing this out in the history is important. The timing of when we start treatment is important. If you start it too early, people may not benefit, or they might in fact find that it's a burden to use therapy. So that you've got to get at a time when lung function is declining and they are starting to develop respiratory symptoms and likely therefore derive symptomatic benefit. Some people may be driven, of course, by trying to improve survival. And so it's important to have that discussion, say, are we doing this for symptom management, or indeed is it important for you to try and improve survival for a particular person? We would always discuss and consider the burden of treatment as well, both for the patient, that it does take time for carers and others to assist with therapy. It might require family or other carers to put ventilator masks off and on and be available to assist during the night. And so that can mean that the carers need to be up during the night to help people with treatment, which over a period of months and sometimes years can obviously be difficult for carers. And we certainly explained earlier the option that if people choose to withdraw treatment, they can choose to do that at any time. Just this briefly a slide to show the importance of when people decide to start treatment, that we need to get on and do it quickly. This is when we introduced the day admission model, which rapidly improved our access to care for starting ventilation. So we bring people in all day to start treatment. We can do that very quickly, usually within a week or two, once that decision is made. And at the time prior to this, we were beholden to getting inpatient beds. The waiting time was going out to a month to get people in on treatment, and survival improved simply by changing to this model where we could bring people in quickly to start treatment. Within Victoria, we have a centralised model for the respiratory service through Austin, but we have, if you like, hub and spokes at many centres in regional areas, Darwin, Bendigo, Frankston, and also a growing number of centres that we work with within Victoria, and of course combined clinics with Calvary Healthcare, where we work in Secretion in Parkdale, and also with a clinic at Beck. But our team supports care in the community with outreach nurses that can visit people at home, and we have a 24-hour on-call service to assist with troubleshooting problems and emergency support. Equipment is important for this group, and because people change, while they may not initially be dependent on ventilation, we know that that can occur within a space of months sometimes. And so we start people on ventilators that do have an internal battery, and as they become more dependent, getting up to 16 hours or more on ventilation, we provide them with 2 ventilators that have internal batteries, advice about having an external battery. And the recent power failure in Victoria really tested that system. There were some adverse events, but no major ones. And it shows the importance of having that sort of backup and emergency systems in place in this population. So I'm going to wrap up and hand over back to Peter, but just reinforce the importance that we do discuss, and really will discuss the goals of this treatment, making sure they have the right supports in place, training family and carers and the right equipment. They're aware of the backup supports that we can provide, and also that they're able to make that decision to cease treatment if they choose to at any time. Thank you very much.
Thanks very much, Mark, and you keeping to time. I'd like to now introduce our second speaker, Rowan Hearn. Rowan is the Clinical Director of Palliative Medicine at Calvary Healthcare Bethlehem, that provides specialist palliative care and oversees the statewide progressive neurological disease service. So a warm welcome to you, Rowan, and I'll hand over to you now. Thank you very much.
Thank you, Peter. Look, I'm going to speak about some considerations of actually managing patients who have motor neurone disease in inpatient palliative care units. This is actually, there is a strong focus obviously on non-invasive ventilation for these patients. And I think sometimes people miss or don't realise that there can be more that needs to be considered for these patients. I'm not going to be focusing on specifics of symptom management, but more general aspects of care. And it should help people to think about actually these patients that we can manage locally in inpatient units. And the reason for this is often we're aware that some patients with motor neurone disease who are on non-invasive ventilation are admitted to inpatient palliative care units for withdrawal of that ventilation. And I think pre-planning for admission of patients with motor neurone disease on non-invasive ventilation really begins with the family, the patient, the family and their carers, to get a better understanding about their expectations of the admission and clarify what exactly they want from the admission, and if things actually change. Is this a patient who is very dependent on their NIV and actually want very aggressive or active management if they deteriorate? Or is this someone who is more focused on symptom management and is not interested in being admitted to an intensive care unit? So there can be a mismatch sometimes between what the local teams feel is the right ceiling of treatment for a patient and actually what the patient wants. So clarifying what the patient and their family expects and actually what can be provided or what's appropriate with an inpatient palliative care unit is very important before actually admitting someone to an inpatient palliative care unit. And I think that the expectations of admission include things like getting an understanding of the extent of carer support and monitoring at home compared to what might be available in the inpatient palliative care unit. For instance, if a patient has a family member or a carer sitting with them almost 24 hours a day, it could be quite hard to provide that level of monitoring and support in an inpatient palliative care unit. The degree of functional ability of a patient with motor neurone disease is also paramount to gain an understanding of before agreeing to admit someone to an inpatient unit. Is this someone who is able to use a nurse call bell? Can they be off their NIV? And if so, how long? What's the length of the period that someone can be off their NIV before it needs to be replaced? This helps the admitting inpatient unit to understand more about the nursing requirements, but also the allied health requirements of these patients before being admitted. And it's very important to make sure that nursing and allied health are aware of what to expect before this patient is admitted to a unit. It's also very important to, I guess, corroborate and confirm this information with local support services. And I've got a full list there, but actually it varies from patient to patient. So for one patient, it might be that the MND advisor is a key point of contact. For others, it's their GP or a community nurse. And so it's really important to identify who's involved with care and support of these patients to get more information, not just about their functional ability, but also what discussions have been had with the patient about ceilings of treatments and advanced care planning. Is there any extra information that's needed about things like communication aids? And this is important. Some community services expect or want an inpatient unit to have discussions about advanced care planning, and others actually there might be a reason where it specifically does not want that to happen. So knowing this sort of information is just helpful to making sure an admission runs smoothly. And I would point out that if someone is under the statewide progressive neurological disease service at Bethlehem, there is a liaison nurse for each patient in clinic who are able to speak to people to give more information. Lastly, with this, I think it's important to get a bit of a, just check the treating team if there's any cognitive dysfunction in a patient with motor neurone disease. For instance, do they have frontotemporal dementia? Do they need a behaviour support plan before admitting them? And it's important that staff are familiar with the ventilator or communication aids, any equipment that they might need to use while the patient is with them as an inpatient. During the admission, there are a number of things to focus on, and clearly Mark has said a lot about non-invasive ventilation, which is important, but it's very important to consider a number of other things during the patient's admission. And I actually think positioning, it sounds an odd thing perhaps to be talking about in detail, but the correct positioning of a patient who can't move for themselves flows through to every other aspect of their care, from communication, swallowing, symptom management, even pain management, and of course, even things like positioning of their mask for non-invasive ventilation. And this patient in the picture on the side needs to be able to cough and clear his secretions by leaning forward to clear his secretions so he can breathe properly. However, he lacks the muscle strength to pull his head back into an upright position. So the solution that was found for this by an occupational therapist was to sew an elastic strap, that's that black band, onto this gentleman's cap so that he could lean forward, cough and clear his airways, and then be gently pulled back into an upright position. And this just is an example of the need for individual solutions for these patients. And also, I've said Goldilocks there because things need to too far in one direction can be just as bad as too far in the other. So extremes can be a bad thing for these patients. And don't underestimate the difference a millimeter makes. As I said, positioning is very important for things like positioning of masks for non-invasive ventilation. The other consideration for ventilation that is often forgotten about is monitoring of the ventilation. And I think it's really important to be aware that some patients might actually have their alarms turned off overnight at home. And this might be something that needs discussion before someone's admitted to an inpatient palliative care unit, is what is the degree of monitoring that happens at home? What is the degree of monitoring that would happen in an inpatient unit? And how will that happen? More importantly, how does this fit with the patient's goals of care and their ceiling of treatment? So this is quite an important part of managing someone's non-invasive ventilation while they're an inpatient in a palliative care unit. Communication is key to making sure that a patient is happy to be admitted to your service again if you run an inpatient palliative care unit. And this is very, very true that a millimeter can make a difference. On the left-hand side, there's a patient who has, the only movement she had left was a slight twist of her head. So the only way of using a call bell was with a jelly bean button, which then had to be put on a stand that was clipped onto the wheelchair side or the bedside. The gentleman on the right has a wireless gyroscopic mouse attached to his head so that he can communicate very effectively through his electronic communication aid on the right-hand side of the screen. Now, for both of these patients, if their communication aids aren't set up from the start, they cannot communicate with all the staff in the inpatient unit. Both of these patients were fully able to make decisions about their healthcare and had capacity to make every decision for any question that was asked of them. Incorrectly setting up their communication aids or even saying, oh, we can leave it until tomorrow when someone who knows about it can set it up, you're setting yourself up for failure because you're effectively gagging your patient, and if you're missing your opportunity to build rapport with your patient by saying, actually, we don't mind if we can't communicate with you for the first few hours or day or two of your admission. Likewise, consideration needs to be given to mobility for patients with motor neurone disease. Both of these patients control their wheelchairs with a scanner. One patient, so a scanner is a piece of equipment that scans through, that shows different symbols, and a slight movement triggers the scanner to select one of those movements. And with the scanner, the patient controls the movement and tilting of their wheelchair. But again, so one of these patients, it was a small movement of their knee that triggered the scanner to work. With these scanners working correctly and set up, these patients had independence to move around with their wheelchairs. So swallowing is a problem for many patients with motor neurone disease. And I'll just say quickly that feeding tubes do empower families and carers to care for their loved ones in the community, but also greatly aid with fatigue management. And it means that a patient is not spending an hour to eat a meal. An inpatient admission is a good opportunity for both dietitian and speech pathology reviews of these, and to also check for what is a safe swallow, because this leads in directly to secretion management. This is the only bit of real symptom management I'm going to give, because I think it's really important that people have an awareness of how to manage secretions of these patients if they're going to be admitted to your inpatient palliative care unit. And a key thing here is about what to deal with a choking episode, which should really be seen as a palliative care emergency. A patient having a choking episode, this is a sentinel event. It's a question of if, not when, this will happen again. It can be very distressing for patients, and if not managed, it can actually escalate, and there can be mucus plugging, which can be life-threatening. A choking episode should be seen as an event that requires immediate multidisciplinary assessment and management from speech pathology, physiotherapy, nursing and medical, amongst others. It's not something that can wait until an MDT the next week or an outpatient clinic. In the future, it needs to be dealt with immediately. And I won't go into detail about management of these things, but things like medication dosing might be slightly different from a typical breathlessness episode in palliative care. Certainly the last patient I managed, 1 milligram of midazolam and 1 milligram of morphine subcutaneously was enough to settle him down so that he didn't fatigue, and then a couple of hours later he coughed up the mucus that was causing his obstruction and indeed was discharged, and that was 6 months ago, and he's still alive today. So managed correctly, these are reversible situations that need to be treated. Of course, there are some patients who need to be palliated, but really it needs to be close attention to identify which ones are reversible and which ones need further palliation. The last thing to point out is just that it's important to make sure that any changes that are made during an inpatient admission are shared with their community treating teams, and that appropriate follow-up is managed. And as I say, I think it's important to make sure that admissions are run well for patients so that they do feel safe, so that if they do want to be admitted to an inpatient palliative care unit for withdrawal or ventilation, that they have confidence in the care that they're going to receive. And thank you, that's it for me. Thank you, Peter.
Thanks very much, Rowan. Greatly appreciated. Introduce our final speaker, and it's Dr. Susan Mathers. Susan is the neurologist at Monash Health, adjunct senior lecturer at Monash University, and clinical director of neurology at Calvary Healthcare, Bethlehem. Some of you may know Susan through your clinical work, but others through, she was also a co-presenter at our annual lecture, which is on neuropalliative care. So great to have you back, Susan, and we look forward to hearing from you. Over to you. Thank you very much.
Thanks very much, Peter, and pleasure to be here. So I could start with my voice. I'm going to spend the last bit of our talk going over the practical aspects of withdrawing ventilation and dealing with MND. It's probably important to say at the beginning that I have always found this one of the more challenging aspects of care of this patient group. I think it is quite easy to intellectualize why we need to be able to offer this to people, how and when it should happen, and that it needs to be done well. But at a personal and emotional level, I think many of us, having experienced this, still find it quite difficult. And it's important that we acknowledge this with our more junior staff as we support them when they experience it as well. Now, discussions about stopping ventilation can happen at various times. Some people never really take to their NIV, and it's often sitting there in the cupboard. That may need a discussion about whether they want to see the RSS again and have some changing of their settings of their masks and really have another go at using it, or whether we should stop tormenting people about technology that they're never really going to want to use, and use other palliative measures. It is important, as Mark said, to have an ongoing conversation about how people want to manage their end of life and how they want to manage NIV if they were to become dependent on it. And that's often because although they may be going along quite well using NIV at night, perhaps a little bit during the day, they can be suddenly tipped in to being more dependent or fully dependent on NIV with something like a life-threatening chest infection. And you may then find families coming to you wondering if the ventilator should be withdrawn because they feel that life is just being prolonged unnecessarily with the ventilator still attached. And it's good to have had that discussion well in advance with patients so you know what their point of view and values are. But most of today, the talk is going to be about the elective withdrawal of ventilation in people who have become ventilator dependent or virtually ventilator dependent. So the goal, as you can see, is always really about optimizing the control of their respiratory symptoms. Now, Rowan has mentioned the NICE guidelines, and I would recommend to you that they cover all aspects of symptom management in MND. They have a section on withdrawal of ventilation, which is also very good. What they recommend is that people like us, who get people onto ventilation, should be available to support and advise people like you who may be requested by patients to withdraw ventilation, and that anyone who has that kind of request should certainly seek advice and support from people who've done it before. And they go through the things that you need to think about in advance, and we'll go and talk a little bit about those now. So, as we've said, it's a conversation over time, ideally beginning before people choose to start ventilation, so that they know that they have this legal right to withdraw when it's no longer of benefit to them. But because they really seldom remember that conversation, we may be talking a year, 2 years down the track when they are reaching the end of life. So it needs to happen over time and be part of advanced care planning discussions and discussions with their medical treatment decision maker. We should, of course, point out that legally this is not the same as voluntary assisted dying, nor is it euthanasia, although it often feels and looks like that, and that's what makes people, health professionals, feel uncomfortable, I'm sure. Knowing the patient and having talked about it with them over time allows you to assess their capacity to make this decision, even when you may be making a decision with their medical treatment decision maker if they're too unwell to have capacity on the day. It is an important, serious decision, clearly, for them and for us as clinicians. And so you do need to be sure that it's a solid and well-considered decision. And I think the fact that it usually takes a little time to put together a plan to withdraw ventilation gives the patient a bit of time to think it over. And it's not only the patient themselves, but this involves family and friends. Often people want others present during the procedure, and all of them have to have an understanding of the legal and ethical ramifications and what to expect during it. I think it's also important to remind you, if you've never been involved with withdrawal of ventilation at your organisation, or if you're going to be going to someone in a nursing home, it is very important to make sure that the senior executive of that organisation understands what's going to happen. I've certainly seen people, things come a little unstuck when it was only those on the floor and the managers of the service that were aware of what was going to happen. So once you feel you've got a valid request for withdrawal of ventilation, the next important question is about how dependent you feel the patient is on their machine. And the literature is not necessarily that helpful here. And often it is about contacting the RSS and making sure they're also in agreement. You're certainly welcome to discuss the patient with us, because we might have some idea of how quickly their disease has been progressing and how there have been changes to the degree of dependency on ventilation over time. knowing how well the patient tolerates being off the ventilator when they clean their teeth or sometimes have a shower, and how long they can be off the ventilator before needing to go back on. And often in these people who are becoming pretty dependent, it is really only minutes or 10, 15 minutes that they can be off the ventilator before being very uncomfortable. You may want to have a look at what their respiratory excursion looks like, particularly when they're off the ventilator, what the effort of breathing looks like, and what their SATs are doing. But ideally, one wants to come to a decision that they are reasonably dependent on the ventilator for 22 out of 24 hours is a rough guide. Although in other studies, people have looked at even being on the ventilator for 16 hours as being dependent. The other thing I would say is it's important to ask yourself how much anxiety feeds into the person's dependency on ventilation, and to address that. I like to have patients trial like an SSRI to manage anxiety, and we've even sometimes put a patient on a very low dose of a syringe driver with maybe 5 or 10 of midazolam and perhaps some morphine, just to see what effect that has on how comfortable they are. And you'd be surprised how many people can actually come off their ventilator for longer periods and sometimes no longer wish to have ventilation withdrawn because they're much calmer. So once you have made a decision that this is the person's request, and you're sure that they wish to proceed and that they're reasonably ventilator dependent, how do we go about preparing? It's certainly important that this is led by a senior clinician, and I think that should be the senior doctor, because we're talking about giving fairly large doses of Schedule 8 drugs intravenously, and the doctor is going to be responsible for doing that. It's not something to leave to junior staff. It does have a multidisciplinary flavour to it, and the whole team needs to be comfortable with what's happening, particularly if this is happening in the ward. I've said here that it is underscored that it's an elective plan procedure, and I obviously made that point already, that you'd be surprised, I suppose, and maybe not, that once a patient makes a decision like this, often they are hot to trot and they really want to get it over and done with. And so they need an understanding over time that it usually can't be done immediately, and that we have to pull together the right people and get them to the place they want to be withdrawn. And that may take a day or two at least, if not longer. But it is common for family to be ringing, wondering where you are, even a couple of hours after the decision has been made. And I think you have to be very careful not to be pushed to starting something that you've really not planned and prepared for. That's when things come unstuck. Most people will want to have this done at home, but a few people request that it be done in hospital rather than in their own homes. And we obviously try as much as we can to comply with that. It's important to take some time beforehand to sit down with the people in the family or friends who are going to be present during the withdrawal, just to make sure that they understand what's going to happen. Many may not have seen someone die before, and they need to be aware of the agonal breathing that they might witness, the colour changes, etc., that they might witness. And they need to be reassured that they should feel free to say that they don't want to be in the room at the time and perhaps just be in the home and come in later. And similarly, you do need to sit down with the clinical team, because some of them will just as much as the family. And they shouldn't be expected to be part of the team. They should be allowed to say that they don't want to be part of it. And we've talked about organisational considerations. You are going to, particularly if you're going out to someone's house, you may need quite a lot of medication in reserve. And that can be difficult. unless you can take it from your own pharmacy and then take it back unopened. But you don't want to be halfway through and find that you've run out of drugs. And the same goes for the kind of other equipment such as IV lines and syringe drivers that you might need to use. You need to think about what's going to happen after you've removed the mask, particularly if the patient doesn't die, because there are certainly cases in the literature where people have not died many hours after the mask has been removed, and you're going to need to work out a way that that person is going to be kept comfortable over a longer period of time. Consideration also needs to be given to bereavement follow-up for the family and what kind of staff debrief is going to be needed. So, oops, I think we didn't talk about the drugs. People do need to think about the medication. Most publications on this topic and our own experience will use morphine or another injectable opiate combined with midazolam and an antiemetic in the drug management of this situation. Whether other medications are included depends a lot on what else the patient's been taking in the last few weeks and months of life. And there are times when we need to consider the use of phenobarbital if the patient's already on very large doses of sedating medication for palliation over recent weeks and months. That's not common, but sometimes we are in that position if they've been on these medications even before the diagnosis of MND. The goal is always deep sedation to make sure the patient is deeply asleep during this procedure. And for that, we always recommend intravenous access, even when you've used a syringe driver in days leading up to the withdrawal to get the patient sedated in the first instance. There are accounts in the literature using subcutaneous sedation. I myself would not feel comfortable with that. And I think some of the descriptions in the literature suggest that it's not adequate. And of course, the doctor who's administering the drugs needs to stay with the patient throughout the procedure. So once everyone's ready to proceed, you do start with an IV bolus of the medication and assess the level of sedation. Usually that's trying to call to the patient verbally, see if they respond to voice, see if they still have a blink reflex when you tickle their eyelashes, and perhaps a painful stimulus like a bit of a sternal rub to make sure that they are deeply sedated. You then begin a period where you wind down the ventilator settings, and I'll let Mark perhaps discuss the details of that if people have particular questions, and observing them for a few minutes in between times to make sure they're remaining and looking comfortable. And you may need to keep topping them up with medication during this period. Once the mask has been removed, you will probably need to continue giving small doses of medication just to make sure that you're not allowing the patient to look uncomfortable, particularly for all the rest of the people in the room. You need to reassure them and describe and explain what they're witnessing. And you need to stay with the patient till they die. And just lastly, I said you sometimes need quite large doses. I was surprised myself when I was first involved just how much medication people need over this period of time. This is some information that was published last year from the UK, where people were asked to write in with how they had gone with withdrawing ventilation according to the Association of Palliative Medicine guidelines. And they were using up to 120 milligrams of midazolam, and patients, and the median time to death from removal of the mask was about half an hour or less. But they did have some patients that lived on for many hours. And I think you can tell from their tables that some of the patients were not ventilator dependent at the start of the process. This compares to higher doses that have been published from other countries. And we've already talked about the need to be mindful of how people experience these episodes of withdrawal. So these are my references, and I think we're ready for questions.
Thanks very much, Susan, and that's fantastic. And well done all of you for truncating your presentations to 15 minutes each in a very complex area of consideration. So thank you on behalf of all of us. We'll go straight to the questions. A number have come in, and we've got some limited time. A question from Rupert, who a particular question highlighted for Mark, is how do you discern which patients are offered invasive ventilation via tracheostomy, please?
Yeah, it's a good question we spend a lot of time on. So I guess we don't usually raise it, is the first thing that I would say, but we're open to discussing it for somebody who talks about it. And we have had over 20 to 30 years that I can think of a small number of people who have gone down that pathway. The discussion we would normally have is to explain what will happen when people go on to invasive ventilation, that there'll be progression of other weakness, and of course people eventually do or historically become locked in, although obviously modern communication aids have enabled communication for longer for people who have gone down the pathway of invasive ventilation. We also describe the supports that are required, and for many people that it may be difficult or impossible to continue to live at home. And I guess in terms of the individual features, we would obviously talk about the disease stage, cognition, if there was frontotemporal dementia, whether the person can actually participate and understand this decision is clearly important. All I can say is when you go through that discussion with a number of people that have asked about it, a number of people who've decided to go down that pathway, let's say in the last 10 years, I could count on a few fingers, and that very few have actually decided to make that choice.
Thanks very much, Mark. And a question for any of you who feel comfortable in responding. A question from Laura, who is interested in the panel's opinion on the use of VAD alongside ventilator withdrawal. So any comments or thoughts there, please?
I'm happy to make an initial comment, so I think in somebody who is, it does come up, we do have raised, but in somebody who is really ventilator dependent or close to becoming ventilator dependent, the process of going through considering the withdrawal, VAD, takes some time. So that takes, several weeks usually to go through, and there is really no advantage in considering that over the process that Susan has described, which had in place for many years, where we can comfortably withdraw treatment, that we can do that without having to go through the sort of legal other process required for voluntary assisted dying. So I don't think we've ever gone down that pathway for a ventilator dependent patient or somebody who's close to ventilator dependent, because we have a very good process which we can act on fairly quickly. And usually it's just going to draw out the decision-making process and the practicalities to go down the path of voluntary assisted dying, but with no benefit over a process that's been very well established and make people very comfortable as treatment is withdrawn.
Thanks very much, Mark. And this needs to be our last question, and it's from Kelly, who's just wanting to clarify, please, with regards to the NIV withdrawal procedure. Have the family typically had a chance to say their farewells just prior to the sedation being administered?
Perhaps I can answer that one. Yes, I mean, I think particularly, the ward needs to facilitate that families spend as much time as they want to, and you need to agree what what the day and time of it, is going to work for everyone involved. At home, I think people often take that opportunity to have, quite a few people in the house, and it can be quite challenging for staff because people choose to have family and friends present, and spend time with them prior to the sedation starting. People need to understand that once you start sedating people intravenously, then they're going to be asleep within seconds. And so anything that needs to be said needs to be done beforehand.
Thanks very much for those responses. We do need to draw the session to a close. So again, to our presenters, thank you very much for your time and effort. Prior to COVID, we hosted these hot topic seminars in person, and you would have had a crowd of 100 or so applauding you. So just perhaps imagine that in your minds, if you will. And but one of the pluses of this format is that we've got several hundred online who I'm sure are very appreciative of your time and the very important information you conveyed today. So thank you very much indeed. Thank you too to everybody who's attended the webinar, and there will be an opportunity, a query came in for whether or not this is made available. It'll be on our website within a few days. So I encourage you to look at the Centre for Palliative Care website, and this whole presentation will be made available to you. Thank you very much to the Centre for Palliative Care staff who make these webinars run smoothly and organise so many things. So on behalf of the whole team, thank you very much indeed. And I wish you well, and I hope to see you all soon at our next event. And thank you again for your interest in the evolution of palliative care. All the best to you. Thank you.